Save. Okay, now we are recording.
Awesome. Okay, I think so. This meeting is just about discussing data extraction for the PTSD review. I guess the management has really changed since before, so I think it would be good if we just talked about the data extraction sheet, just so that we're all on the same page. And I don't believe we have many guidelines from before to work off of, so I think it's good for us to internally discuss our decisions on how we should extract the data and all the outcomes.
Great, thank you. And I think Hussein is here, so.
Hussein, can you hear us?
Yep. Can you guys hear me?
Yeah.
Yes.
Okay.
Great.
Hussein, did you want to introduce yourself just to the group?
Oh yeah, of course. So my name, of course, is Hussein. I am a second-year HR master's student. I am working on a project looking to improve the reporting of pilot studies in the HIV literature. And my supervisor is Dr. Lawrence Mbwagwa.
Great.
Nice to meet you.
Likewise.
Good. So who's going to take charge? Dana, Elena?
Do you have the like the data extraction sheet on your computer, or?
Yes, I do.
Okay.
So I think the best approach, and Ben, feel free to suggest other ways we can handle this. But I think the best approach right now would be for us to start with the dropout data that we need to re-extract from the studies that we already have. And then once that's done, we can then transition into extracting data from the new studies from the search. And from my understanding, there's only actually a few studies, so it shouldn't take us too long.
Yeah, let me. This sounds brilliant. Let me give you just one quick background about what's going on. So this is a very large NMA. You're dealing with almost 200 studies, or let's say more than 100 studies. Technically, this is a network meta-analysis looking at the effectiveness and harms of pharma and non-pharma interventions targeted at treatment of PTSD. And so there's a group of people involved in the extraction of the effectiveness outcome, like the symptoms score, quality of life measures, function, return to work. So there was a set of, I think, 5 to 7 effectiveness outcomes. And but a problem was there were some mistakes in the data extraction. So Dana and couple of other colleagues of hers, they went through these PDF articles, and then they checked if the actual data was extracted correctly, and if not, they've corrected that. This is the first time that we're trying to capture harm outcomes instead of looking at individual adverse event outcomes. We're looking at a surrogate outcome of tolerability, which is dropout rates due to adverse events and dropout rates due to all cause, so any reason for dropout. And originally, when Yasir and his team, they did the extractions. They did that work inconsistently. So they've captured this information and that information. And then the problem was for a lot of these non-pharmacologic, then I will go through the details of this, but for a lot of these non-pharmacologic interventions, the duration of treatment and the follow-up are different. So and the idea is you do CBT, psychotherapy, or exposure therapy for these patients, and the effect is supposed to last for a long period of time. So they do these 6 sessions, 10 sessions, 12 sessions of these treatments, and then they still follow patients after the treatment duration is done. And unfortunately, for a lot of trials, as you continue the follow-up, the longer you follow patients, the number of missings get out. So I'll leave Dana to explain what a strategy we have come up with to avoid that problem. But here we are, and we're trying to capture a valid estimate of tolerability for these based on these 2 outcomes. Sorry, Dana.
Yeah, no worries. Great explanation, Benham. So yes, so essentially we are extracting dropout data, and we're extracting dropout data due to adverse events and due to any causes, essentially. And we are using these outcomes as surrogates for potential harm caused by the interventions. So I think the best way to do this would be for me to share my screen and to sort of walk you through the data extraction form that we have. The process is actually really simple, so it shouldn't take too long. So I'll just try to share my screen. I've never done this with WebEx before, so Benham, you might have to walk me through.
So there's an icon that says share content down there that you have your camera microphone thing. If it doesn't work, let me know. Oh, okay, good, it's working.
Okay, excellent. Okay, so yes, so I sent you guys a copy of this sheet just a few seconds before, and the first tab of the sheet includes instructions regarding how we are going to extract the dropout data. And I'll go through these instructions with you just quickly right now. And then there are 2 other tabs. One is for extracting all-cause dropouts, and the other is for extracting dropouts due to adverse events. So all-cause dropout refers to dropout from any causes, including adverse events in the study. And the tab for dropouts due to adverse events will be solely for the patients that dropped out from the study because they were experiencing adverse events. And you will find that only the studies, or primarily the studies that report on pharmacological treatment, so drug trials, etc., are going to report dropouts due to adverse events. Now you'll come across, I think, a few cases based on the sample that I've gone through. You'll come across a couple of cases of non-pharmacological trials that actually report dropouts due to adverse events, but it will mostly be the pharmacological trials that report this, and that's okay. So essentially, what you would start off with doing is that we will share with you a folder containing PDFs of the included trials, and you'll be put into pairs to do this. And the first 3 columns of the data extraction sheet are just the study ID, the ref ID, which is just the number in the name of the PDF, the name of the first author, just the last name of the first author, and then the year. The next 4 columns are to capture the interventions that are tested in the study. So this is very self-explanatory. So it'll either be the name of the drug, or it will be the name of the non-pharmacological intervention, like I don't know, like cognitive behavioral therapy or something like that. So depending on how many arms there are, I think you'll find that none of the trials actually have more than 4 arms, but depending on the number of arms there are, you'll just fill in, intervention 1 or 2 if there are 2 arms, or intervention 1, 2, or 3 if there are more than, 2 arms, if there are 3 arms, etc. And then the next few columns are the actual dropout data. So for each intervention, you'll record the number of participants that were randomized to that intervention, as well as the number of dropouts that were observed. So in this tab, because this is all-cause dropouts, I would record all-cause dropouts. And here, because it's due to adverse events, then I would record dropouts due to adverse events. Now, capturing dropouts due to adverse events is actually pretty simple. It's very straightforward. It will usually be reported in the text. They'll say this many participants discontinued the treatment because they were experiencing some sort of side effect or whatever, something like that. What is really tricky, though, is dropouts due to adverse events. And this can be reported in a number of different ways. And I think the best thing to do now is just to go through our instructions for extracting the all-cause dropouts. So when we say all-cause dropouts, what we actually mean by that is not the number of people who didn't complete all sessions of the intervention or who didn't take all of the medication that they were randomized to, or the number of people who only attended a certain proportion of the sessions of the intervention, or who only, took 80% of the pills they were prescribed. We are not referring to that at all. What we're really interested in is the number of participants who are randomized to a particular intervention, but didn't complete the outcome measure at the end of the treatment period. So this number may actually include the participants who didn't complete all the sessions, or who completed a certain number of sessions, or who didn't take all the medications, or who took only a certain number of medications. But really, the way we want you to extract this data point is by looking at the number of people that didn't provide follow-up outcome data at the end of treatment. Now I'll just stop there to see if anybody has any questions regarding what I've gone through so far, and then I'll go through a couple of other points.
So just to confirm, does that mean if one did not complete all the session, but we have the data of this patient, that's not a dropout, right?
Yes, so you'll find that actually in a lot of the non-pharmacological trials, they'll report something like 5 participants only attended 60% of the sessions. And so we think that this is more of an adherence issue and not a dropout issue. And so we don't want to conflate these two concepts together. And so what we're actually really looking for is the people who did not contribute follow-up outcome data at the end of treatment. Does that make sense?
Yeah. And another question is for the data extraction sheet. So for the intervention, name of the interventions, do we already have the data of them in the previous extraction? I mean, if we can just use that and just unify the extraction.
That's a good point, Xiaochen. Abanam, what do you think about that?
So I was going to say, if forget about what is in previously extracted. Just put 1, 2, 3 word maximum. Doesn't matter. Doesn't matter if you first put the control or placebo or you start with intervention. Doesn't matter at all. There are some of these things that you just don't understand what it is. And it's like a paragraph of intervention. That's why I don't want you to go back and look at what is already extracted. We have these studies, Jason and I sat together, read that whole paragraph, that decided that, okay, this is called this. So just use whatever they've named the intervention in the abstract or in their tables. That one word or that 2 word or that phrase that they named the intervention, just use that one. Don't worry about it. We'll figure it out. The key here is to keep this worksheet clean and not so many words. So I don't want you to copy and paste the paragraph in there or try to figure out what is the intervention. If they mention that this is called attention bias modification, just put attention bias modification. If it's called exposure therapy with space, put exact quote unquote that they called the intervention. And don't worry about it if we have already looked into these things. We also sent out all these explanations to a group of psychologists to confirm if the categorization of the intervention that we decided make sense. So I don't want you to go back. I don't want you to double check the previously extracted data, because all that already have changed. The only thing I want you to do, use either the abstract or the table or the flow diagram and figure out what is it that the authors called their arms. Copy and paste that in there. Does that make sense?
Yeah.
I have a question. What if it's not clear that people followed up or didn't follow up due to lack of adherence versus lack of actual follow-up? Like, the distinction that you were making before. What if the authors don't clearly report the lack of participants at the endpoint due to one of those two options? Should we just not put any data in?
That's a great question. So for all-cause dropouts, we are just going to look at the difference between the number of people that were randomized and the number of people that were included in the analysis for the outcome data at the end of treatment. So we don't care what the reason is that they were not included in the follow-up outcome data analysis. So we're just looking at number randomized minus the number that were included in the analysis for the end of treatment.
Okay.
Whatever the reason may be that they weren't there, we acknowledge that it's a little messy. We're not really sure if it's due to tolerability, lack of adherence, or maybe they just, they were excluded for a completely legitimate reason, like they were not eligible. We're just looking at all causes, and we recognize that there is going to be some noise, but because there's going to be noise across both or across all the arms in a trial and across all the studies, then it's okay. Then it's not, the data isn't necessarily being biased a certain way. Does that make sense?
Yeah, that makes sense.
Excellent.
And the other thing is, it's going to be a little bit complicated in the first 5-10 studies that you're going to look into. And it's totally fine to contact me and Dana and said, hey guys, have a look at this. I'm not sure which number I should, extract. It's totally fine. If I think both Dana and I strongly encourage you to do so.
For sure.
In the first, yes. So if something is even a little bit you're not sure, it's a little bit complicated, just send us an email. We don't want you to guess anything. For the studies that are published in good journals after 2005, 2006, most of them, they have a flow diagram that says, here's the list of people who were lost to follow-up. Here's the list of those who are lost to follow-up due to adverse events. Those are the easiest one. As it gets older and the journals get a lower quality, it gets more complicated, because now they report something in the discussion or something else in the result. So it can be very tricky. And the other thing is, please look into, so you're going to have three different set of studies. Those that will say, we didn't miss any study, and we didn't have any adverse events. No patients would be observed, no adverse events. In their flow diagram, they don't have any missing due to loss to follow-up, due to adverse events. Make sure that you put in the comment section, make sure that you put that phrase that says the observed no adverse event, and then put 0 in the dropout due to adverse events. I totally forgot about this, Dana, before. Maybe add it somewhere to the instructions.
Yeah, I can make a note. I'll send you guys a new version of the.
Sorry, Dana. It's only due to adverse events. This is only for the last tab. It's not going to be applicable to the all costs.
I'll add this note and I'll send you guys a new version of the data extraction form when we send the assigned articles to each pair.
Great, thank you.
Yes. Any other questions?
Yeah, I got another one. So are there studies that have different follow-up time points? I mean, like maybe few
Yes.
3 months, 6 months, and
Yes.
they may have different dropouts.
Exactly. That's what we're going to get to next.
Oh.
So, as
Dana, may I add one little tiny thing? Please only put numbers in those columns that ask for numbers. Don't put anything else.
Yeah, so we want to keep the data as clean as possible. So when Benham goes back and analyzes, it's easy for him, so he doesn't have to, do a lot of major cleaning. And I'll go through beforehand before I pass the data off to Benham and make sure that the names of the interventions here actually correspond to the coding that was done by our panel of experts, sort of. So as Xiaojun brought up, there are most of the studies, in fact, are going to report on multiple outcomes, and they are going to report on outcomes at multiple time points. So how do we choose? And so these analyses, the analyses for different outcomes and at different time points might have a different number of participants included in each of them. So that's going to affect the dropout numbers. And so what we want you to do is to choose the analysis or the data that's reported for the longest point of follow-up at the end of treatment. So that means that suppose there is a trial and the intervention was administered over 3 months and the patients were followed up from randomization up to 6 months. So 3 months of treatment and then 3 additional months of post-treatment follow-up. So we want you to look at the number of participants that were included in the analyses for the time point closest to 3 months, because that's the closest time point to the end of treatment. Does that make sense? Does that answer your question, Xiaojun?
Yeah.
Okay, excellent. The other issue is that there are going to be multiple outcomes, and so analyses for all the outcomes might actually have different numbers of participants included. So we've actually created a sort of hierarchy for you to use to select the outcome and analysis that will inform how you calculate the number of dropouts. So first, you will look for the CAP scale or any other measure of PTSD symptoms in the PDFs. And these outcomes are already highlighted, so it'll be really easy for you to identify them. If this outcome is not reported, then you will look for the physical component score of SF36. Again, if SF36, the physical component score, isn't reported, then we'll look for the mental component score. And then we'll just keep going down the list. So preferably, we would look for the analysis that's at the end of treatment for CAPS or any other PTSD symptom score that's reported. And if that's not reported, then we'll go one down the list, and we'll keep going until we find one outcome measure that's reported. Does that make sense?
Mm-hmm.
Yeah. So that's pretty much all I had. Benham, am I missing anything that I should highlight?
No, everything is good. Yep.
So if you guys have any more general questions, we can address them now, or...
So one last question from me. The skills here is an exhaustive list of the skills, right? We will not meet others. I mean the measurement here.
So is this an exhaustive list of the
Yeah.
outcomes? Yes.
Yeah.
So all of these studies will report on at least one of these outcomes, and they're all highlighted. So it'll be really easy for you guys to actually find them.
Sure.
Well, they're highlighted in the first set that we'll send you, but once you actually extract the new studies, those aren't highlighted. But by then you'll have a pretty good idea of how to do them and what they look like. So. Okay, so if nobody else has any other questions, then I guess you guys should look forward to an email from Benham and I with the assigned studies for the dropout extraction.
Perfect.
Thanks, everyone.
Sounds good.
And you will have, the first few studies will be very, very tricky. So please, please, please send Benham or I an email, and we will be happy to address any questions that you have. Some of these studies are actually quite difficult for even us to really figure out, like, what the number of dropouts should be. It's tricky. Sometimes it's a little murky, and there's not always a very clear answer. So it would be good to actually flag those studies to think about and to discuss amongst the group.
Sounds good.
Excellent. Great.
Perfect.
Thanks so much, everyone.
Thank you so much.
So
Thank you.
I have a few minutes
Great.
on you.
I have to talk to Dana and Holly after this meeting, but do you want to talk around 3:30, 4? Does that work for you?
Okay. Yeah, sure. use Skype.
Just text me in Skype, and then we'll talk.
Okay.
Thank you.
See you.
Sorry, question for Benham and Dana. Did you still want me to like compile everyone's answers into a single spreadsheet, or did Dana want to take over that responsibility?
That would actually be great, Elena. And if we could actually schedule another time to touch base, if you could
Sure.
also help with the distribution of the studies and the collection of the Excel spreadsheets and stuff, that would be super helpful for us if you have the
Yeah.
time.
I do. I just don't have access to the full list of articles that are needed for dropout and stuff. Yeah.
Yeah.
Okay.
Yeah.
And yeah, just send me the final extraction sheet, and either you can send that out to all the reviewers, or I can send it out. It doesn't matter.
If you have time, it would be great, Elena. I'll touch base with you out in like an hour or two.
Yeah. That sounds great.
Great,
Okay.
thanks so
I'll
much.
talk to you then. See you.
Great. Thank you, everyone.
Bye.
Hey, I think Dana, it's just us now.
Excellent. Okay. So in addition to what we just discussed, there is another issue, the extractions that were previously done that we'd like to correct now. And this is more of like a different methodological decision that we made in terms of how best to pool the data. And it has to do with the time points at which the outcomes were originally collected. So Holly, if you have some time, if you would be able to help us out with this task, it would be very much appreciated. Since you're already going back through some of the studies, while you're going back through the studies, then you can also flag the studies for which the outcome data was not optimally extracted, and then we can actually go back and re-extract those. It shouldn't be too many of those.
Okay.
Excellent. Okay, so I guess the best way to describe what we're doing is, and Benham, feel free to interrupt if there's a better way to go about this, but essentially there are two types of studies that we're dealing with. there are the pharmacological studies and there are the non-pharmacological studies.
Right.
So for both types of studies that we had, originally the data was extracted for the longest point of follow-up. So if an intervention, was for 3 months and then the study followed participants up for 6 months, then the extractors extracted data at 6 months.
Okay.
But the issue is, for the pharmacological interventions, we think that it would actually be better if we pooled effect estimates that correspond to the end of treatment rather than end of follow-up, because with drug interventions, we don't expect the drugs to have any effects once you stop taking them.
Right.
Does that make sense?
Yes.
Yeah, so we have, I've pulled up the extraction sheet for what we have right now. Can you see my screen, Holly?
Yes.
Yeah, okay, excellent. So essentially what we would want you to do if you have the time and the interest is to go through the trials, look at the outcome data only for the pharmacological trials, and you'll see, the interventions are coded here. So for example, I would not go back to a study on CBT, and because that's not a drug trial. I would only look at the drug trials.
Right.
And then I would look at the outcome data that's extracted, and I would see what time point it corresponds to. And if it's a drug trial, and if the outcome data corresponds to post-treatment follow-up, then I would flag that study, re-extract the outcome data that corresponds to the end of treatment.
Okay.
And there shouldn't be too many of these. I know there are about 50 pharmacological trials, and I already went through a sample before this call, and out of the sample of 20 that I went through, there was only 2 where there was post treatment follow-up. So it shouldn't be too many at all.
Okay. Is there a specific way that you want me to highlight that it's been edited or flagged?
I think that would be up to you. Maybe highlight I know there's highlights all over the spreadsheet, unfortunately. But if you could highlight in a color that's not already used for.
Okay.
No, so why don't you add a column after the changes score, like column go to column after column O or something, and put comment or something like that, or need change, something like that. There are a lot of abbreviated treatment codes in here, which are mostly non-pharmacologics. If it is pharmacologic, it's the name is there. But if you had any problem figuring out which one is pharma and which one is not, just shoot an email to me or Dana, and we'll tell you. From
the that I went through, it's pretty clear which ones. I don't think that should be too big of an issue. Maybe we'll have you'll be confused for a couple of them, but really it shouldn't be. It should be pretty straightforward. The other thing that I wanted to sort of walk you through with this spreadsheet, it's Holly, have you worked with this data before?
Sorry, this data set or just data extraction in general?
No, just this data set.
No, I haven't.
Okay, so I'll just kind of walk you through. So each of the outcomes are sort of recorded in a separate tab in the data extraction form.
Right.
And so, for example, we're looking at CAP symptoms right now. So this is the PTSD symptoms.
Okay.
The next one is the physical component score of the SF-36.
Dana, I think you have a few worksheets before CAP symptom.
Yes, just the baseline characteristics.
So
but you
definitely ignore that one.
Yes. So just the outcome data.
Okay.
Quality of life, and the disability, the Sheehan disability scale. Please ignore the ones that are in red. You can, completely disregard those. And so in these outcome spreadsheets, or in these outcome tabs, each arm of the trial is recorded in a separate row. And we have the baseline measure and the end score measure and the change. So we want to see whether the end and the change correspond to end of treatment follow-up or post-intervention follow-up, essentially.
Okay.
Just for the pharmacological ones. So what you would do is you would go through each of the studies. So first I would start with number 2. So this is fluoxetine. That's a pharmacologic intervention. I would pull it up, look for the end score, so 38.69 with the end score standard deviation being 20.30. I would look for this number in the paper, and I would see if it corresponds to a post-intervention follow-up, immediately post-intervention, or if it's follow-up, a couple weeks or a couple months after the intervention's already been administered.
Okay. So if it's been extracted for the longer time period, do you want me to just make a note that like, oh, this is wrong, this needs to be fixed, or do you want me to fix it myself and then just mark that I fixed it?
So
Okay.
you could actually correct the values in this extraction sheet, but also to flag that study.
Right. Okay.
Everything has to be done in duplicate. So then I would go back, look at the ones that you flagged and the re-extraction that you've done, and I would re-extract the data as well, and then I would look for discrepancies, and then we would just have one set of extractions at the end that has been corrected.
Okay, perfect.
So that's why we're asking you to flag as well as re-extract.
Okay.
Anything else, Benham, that comes to mind that I might have ignored?
No. The thing is, Holly, so the studies mostly report CAP symptom.
Okay.
So the biggest number of if I think it's more efficient if when you open one PDF, go through different tabs.
Yes.
And instead of finishing one tab and then going to another worksheet and then another, because then you'll have to open each PDF multiple times.
Right.
So I think that's faster.
Okay.
And if you couldn't, so what I would do is open the PDF, Control F, search that number, see if you can find that. So don't spend a lot of time in there. If you can't find the number in the paper, then there's a problem.
Okay.
And then you let me or Dana know that what is happening, and then we can look into that study. So and if you had any question, if something was not clear, just send an email to me and Dana, and we'll talk.
Okay. Yeah. So these are some of them are actually pretty tricky and confusing. So I expect that there will definitely be questions. So feel free to reach out if there's any confusion with regard to
Okay, thank you.
And I'm sure like the first few again are going to be kind of tricky, but then you'll sort of get the hang of it.
Okay, perfect.
Good. Holly, you're also helping with the post-surgical sore throat screening, right?
Yes.
So I don't know how people do things at different speeds, and it is fine. For none of these studies we have a tight deadline. We don't have any tight deadline for anything. We're not in a rush.
Okay.
But we care. What we care is quality.
Right.
It's very important to that's kind of the difference between working with industry and working with academics. We people don't care about the time. We don't care about the money. What we care is the quality. Okay. So don't feel that there's no rush. Don't feel that you have to finish things fast. The key here is to do things as correctly as possible. And I don't know how much time you have on your hands. So if you thought that, okay, these are going okay, and I have some spare time that I can work on something else, let me and Dana know. If you think, oh, what I'm working right now is too much, I need to cut down. Again, let me, Dana, or Vahid, who's taking the lead on the post-surgical sore throat know, so that we can cut the amount of work that you're supposed to do.
Okay, yeah, I think it'll be fine. I've got lots of time right now, so.
Okay, yes, that's the thing. We don't want to put you under a lot of pressure that you have to do things. But at the same time, if you think that you have more time and you can work on something else, there is so much work that we need help with, and Dana and me, we can give you something else to work with,
Okay,
on.
perfect. Thank you. I appreciate that. Yeah, I'll definitely let you know. I'll get started on this, and if I have more time, I'll let you guys know.
Good, great.
Thank you so much, Holly.
No problem. Thank you.
Great. Dana, is there anything else that we need to talk about?
Nothing related to PTSD, no.
Okay. I'm gonna send out an email. So just giving both of you a heads up for a team meeting, probably next week. So I was talking to Jason yesterday, and I think everyone can benefit from having like a team meeting to go over the projects, who's doing what, who needs help with what. So it's probably going to be next Thursday, but I will send a doodle pool by the end of today. So if there's anything that, while you're working on projects, if there's anything that comes up that you want to discuss this with the team, we will have a meeting next week.
Okay,
Sounds
great.
good.
Great. Thank you both. Enjoy the rest of your afternoon. And let me know if you had any problem, if you wanted to talk more about the projects.
All right. Thank you both.
Thanks,
Take care.
Bye for now.
Bye.
Bye.